Hello, and welcome to this week's episode of Medisodes. Today, we're going to be talking about GPs, the gatekeepers of the NHS. So, there are over 1.3 million GP consultations every day in the UK, and these range across the spectrum from heart disease to cancer to mental health problems. GPs encounter every single type of medical speciality, and that's what makes it so exciting. So in our second ever episode, we talked about the structure of medical training, and if you want to learn how to become a GP, please look at that. We'll link it down in the description. So what do GPs do? Well, I would split it into the medical side and the admin side. On the medical side, GPs have consultations with patients, and unless you go to A&E, they are the first point of contact with a medical professional if you have a problem. The GP will assess you. They might examine you by using stethoscopes, or they might ask you to do certain tests. And from that, they can gain what's wrong with you and what further actions need to be taken. There are a couple of different courses of action GPs might take. Firstly, they may refer you to a hospital where you can see a consultant who is specialized in this field. For example, if you have an eye problem, you'll be referred to an ophthalmologist in a hospital so that you can have specialist care for that. There's also primary care services that GPs do themselves. These include injections and some blood tests, which can be easily done by nurses or the GP themselves. GPs also may give prescriptions. For example, if you have certain skin conditions, they might prescribe you some creams to clear that up. They're also looking for red flags. These can be medical, such as cancer. And if you have cancer, you should be seen within 2 weeks to make sure that you have the best chance of survival if that cancer is present. But these red flags are not only medical. They may also look for signs of domestic abuse, and the GP has a more than medical role within the community. They also serve a social aspect, especially when it comes to mental health services. So the other half of being a GP is the administration. Well, no one likes admin, and it's much more exciting to talk to patients and try and make them feel better. It's obviously very important to make sure that admin is done. So GPs read and act upon letters that they receive from hospitals that they've referred patients to, and they need to take action on that to make sure that whatever the consultants have said gets done. If you need blood tests, the GP will ask you to come and do those. If you need to be referred to another centre for further care, the GP will do that as well. The GP also signs repeat prescriptions for those that need it. Some people with chronic diseases will need just repeat prescriptions that the GP has to sign to make sure that only the people who need those medications are getting them. They also have legal roles, for example, in fitness for work. So GPs will assess whether you're fit to work, and this will affect benefit claims and other things like that. GPs also may have to sign death certificates. So your death certificate has to be signed by a medical professional. And since the GPs have such a large role within the community, they are one of the people that can be, if you don't die in a hospital, they're one of the people who will sign your death certificate. On top of that, GPs are looking to gain points within the quality and outcomes framework, which is a way of making sure that medical practice is to the highest standard. So there are 4 areas: clinical, public health additional services, and quality improvement. And the GP practice is given points based on how well each indicator is done, and those points will translate into funding later on. It's important to note that GPs aren't only limited to the GP surgery. They are also key parts within the community, and they may do home visits, especially to people who are not able to travel to the GP practice. Now that we discussed what GPs do, Anupam's going to dive into how they fit in within the wider NHS.
So GPs are specified by the NHS as independent contractors and are expected to do and are provided funding for this work through arrangements known as the General Medical Services Contract. Today, the GMS contract is a UK-wide arrangement with minor differences negotiated by each of the 4 UK health departments, each for England, Wales, Scotland and Northern Ireland. 70% of practices have a GMS contract as their principal contract, and this contract has subsections which are not all compulsory, but the main body applies to all of these GPs. Practices may also use 2 types of locally negotiated contracts as well to provide flexibility in their service provision, such as the Personal Medical Services or PMS contract, which is used by roughly 26% of practices, and the Alternative Provider Medical Service, APMS contract, which is used by roughly 4% of GP practices. This independent nature of GPs in the NHS via contracting is really important because the meaning of independent contractor in respect of GPs has not always been very clear, but has always been tied to their rejection of salaried status. Even to this day, the NHS publishes their workforce statistics separately to GP statistics. Their behaviour has usually been that of self-employed entrepreneurs, and although as of late they've behaved as salaried professionals, they still defend their right to control what they do and how they do it within their practices. GP contract arrangements were originally made with local executive councils and then their successor family practitioner communities, family health service authorities, and primary care trusts. However, now, in England, the contract is now between the GP practice and NHS England itself. In Scotland, GP practices are contracted by the health boards. Responsibility for commissioning primary care services, including general practice, formally sits with NHS England, like I said. However, in reality, it's not so simple. Over time, clinical commissioning groups, or CCGs, have increasingly taken on full or partial delegation of these commissioning powers for primary care. This now means that most CCGs have most or at least some responsibilities for commissioning general practice in their local area, while also keeping to national guidelines to ensure consistency. Proposals in the past to make GP salaried professionals were rejected by the profession, and from 1948 to 2004, the contract was an individual one. Virtually every general practice doctor had a personal contract with the NHS, and patients were registered with said named doctor. The College of General Practitioners was founded in 1952 and has been an increasingly important player in negotiations about the GP contract and is a driving force in relationships between NHS England and GPs all around the UK. Contracts are renewed every year, but major renegotiations have happened many times in the past, such as in 1966, 2004, 2015, 2017, and most recently in 2019. A note is that the 2019 contract is set to expire by 2024, so we'll probably see another renegotiation then. As of the 31st of March 2021, 35,273 full-time GP staff have been contracted by the NHS, and 70,003 full-time admin and non-clinical staff were also contracted. So what's actually in the GP's contract? Well, the core parts of their general practice contract define the geographical or population area the practice covers, requires the practice to maintain their patient list for the area, sets out who this list covers, and under what circumstances a patient might be removed from it. It establishes the essential medical services the general practice must provide to its patients, and also sets standards for premises and workforce and requirements for inspection and oversight. It also will set out expectations for public and patient involvement, and finally will outline key policies for things such as complaints, liability, insurance, and termination of the contract. General practices are further contracted to perform broadly 5 types of service for the NHS. Essential services, which must happen between 8 AM to 6:30 PM Monday to Friday, excluding bank holidays. Also out-of-hours services, where a practice is assumed to provide these by default but can opt out, and additional services depending on the area. Enhanced services are also nationally agreed services that almost all GP contracts can provide if they choose to opt in. Services specified for the previous year include vaccination programs or health check schemes for people with learning disabilities. In the UK, unlike many countries, patients do not normally have direct access to hospital consultants and secondary care. Instead, this is controlled by the GPs. So, how do GPs get funded? Well, the funding a GP receives through their contract depends on a complex mix of different income streams. The quaffs that Shrey mentioned, for example, is one way, but much of a practice's income comes from its core contract agreements, meeting mandatory requirements, running essential services, and operating the out of hours and additional services where they have been agreed. And this all falls under their global sum payment. Global sum payment. So, about half of the money a practice will receive is from this payment, money for delivering its core contract parts. This includes the payment, like before, of additional services as well as the core services. And if a practice opts out of any of these, percentage deductions are applied to the global sum payment to account for this. Global sum payments are based on an estimate of a practice's patient workload and other unavoidable costs, such as the costs of serving rural or remote areas and the effect of geography on staff markets and pay. It's not actually dependent on the actual recorded delivery of services. So the global sum payment for each practice is based on a weighted sum using the Cahill formula. The Cahill formula applies weightings such as age, gender, or rurality of the GP practice and uses these to determine the sum of money allocated to that practice. The global sum amount for each GP practice is reviewed quarterly to account for changes for the practice's patient population. Overall, GP practices are essentially businesses that run independently to provide services in their area underneath NHS England. However, within these practices, there are different types of GP. To tell you more about them is Surya.
Now let us look at how GPs can vary depending on their responsibilities and work style. There are three main types of GPs. These include GP partners, locum GPs, and contract or salaried GPs. Let us start by looking at salaried GPs. Salaried GPs are employed by an organization and receive a salary. This is similar to being an employee in a company. Locum GPs, on the other hand, are fully qualified GPs who don't have a standard employment contract, but instead are paid per session. Now let us look at GP partners. GP partners have a huge responsibility as they are responsible for running the GP clinic from a business perspective. They have lots of control in terms of determining how the GP is run. They often decide who to hire. For example, they control the employment of salary GPs. And GP partners also control how the GP is run on a day-to-day basis and which services the GP should offer to the local community. This larger responsibility means that GP partners often get paid well. However, being a GP partner can require a lot of commitment, and there may be reductions to benefits such as sick leave and maternity leave, but this can vary depending on specific GP practices. However, being a GP partner offers a greater job security than the other types of GPs mentioned. And one major factor that adds to the job satisfaction of being a GP partner, you get to put your own unique stamp on the healthcare of a community by controlling the healthcare services that a GP clinic provides. As Shrey mentioned at the start, GPs can play a wide range of roles in their community, and this means that there can be many different types of roles for GPs. For example, some GPs might have a passion in sports and might therefore spend some of their time working as a team doctor, for example, in a local football club. In this type of role, the GP will check if the players are healthy before they start playing by addressing any health concerns that the players might have. They will deal with any medical concerns that the crowd of the football match might have, and these GPs might be referred to as sports GPs. Occupational health GPs are GPs who have a role in running occupational health support services. These help employers to reduce and prevent illness in the workplace. Occupational health GPs will also help promote health, and they will give advice to workers that are suffering from health conditions that might be impacting their ability to work. The role of GPs is truly diverse due to the fact that GPs can pursue their interests and specialize in certain medical fields. GPs who specialize in their particular field of interest are known as GPs with special interests, and they tend to be specialists in their chosen field, leading to a wide variety of roles in taking care of patients who suffer from medical problems relating to their speciality. From this, we can see that the role of GPs extends far beyond just the GP clinic or practice. Different roles played by various GPs help to ensure that public health of the community is well looked after, as well as making sure that people in the community can work while managing any health problems that they might have. So some GPs can be said to have a role in helping to maintain the well-being of an entire community and not just the patients that present to them with a problem in their GP clinics. This shows that GPs have an important role in public health as well. Now on to Adrian, who will be talking about GP shortages.
It's not new news that there's a shortage of general practice doctors in the UK. It is not only general practice that suffers from a shortage of doctors, the whole NHS suffers from a shortage of healthcare professionals overall. I will start by discussing reasons why there's a shortage of doctors across the NHS, before moving on to focus on general practice specifically. Data from early 2020 suggests that the UK has 2.8 doctors per 1,000 in the population, which puts it well below the average of the European Union, with only 4 countries having lower numbers per capita from the European Union. A report by the Royal College of Physicians in 2016 suggested that the UK did not currently train enough doctors to meet demand, pointing to evidence that there were fewer medical students in 2016 than in 2010, despite a large rise in the number of patients using the NHS service. There are a huge number of long-term job opportunities available in the NHS, with the number of advertised medical and dentistry full-time equivalent vacancies for NHS England at 9,217 in September 2018. However, this lack of medical students does not seem to correlate with the fierce competition that there is for places at all medical schools, with competition increasing as the university's reputation increases. For most degree subjects, the government allows universities to take in as many students as they would like, and as many students as they can facilitate. However, the number of medical students is controlled by the government. Reasons for such control include the considerably higher cost of providing training for medical students. The difference has somewhat been made up by increased immigration over the past century, bringing in doctors trained from elsewhere to work in the NHS, but this is not enough to make up for the increased demand for NHS services. The deficit of medical school places has been recognised, and medical school places have planned increases over the next decade, with several new medical schools opening, such as Sunderland, Lincoln and Angela Ruskin. However, the plans have been described as too little, too late. This is because the increase in medical school capacity takes time, such as the time taken to build new facilities to accommodate these new students. And on top of this, the career progression of a medical student to a fully qualified doctor takes a long time. As Shrey has mentioned, be sure to check out Medisodes episode 2 for in-depth coverage of the career pathway of a doctor in the NHS. A recent article by the British Medical Journal reports that just over a third of doctors who complete their foundation training continue directly into specialty training in 2018. This is a reduction from the 42.6% who continue into training after the foundation years in 2019. Furthermore, the same study showed that over 14% of doctors plan to take a career break after their foundation years, with data suggesting that burnout is a significant contributory factor that seems to peak at foundation year 2. Is this a reason for the lack of workers in the NHS, especially general practice? Burnout and overworking have been a continuous issue raised by healthcare professionals working the NHS, especially as the NHS loses doctors faster than they can be replaced through the training of new medical students. Experienced senior skilled clinicians looking to reduce or end their commitments to the NHS is a cause for alarm, since all these workers have had significant training and experience that makes them valuable to the running of the NHS. The problem of burnout is perhaps exaggerated by the COVID-19 pandemic, with the overstretched NHS workers being asked to do even more work and stay for even longer shifts, work for which there is no longer time in the day. Though this is a very specific case, this scenario has exaggerated the lack of staffing in the healthcare system overall, and it is only through the COVID-19 pandemic that the understaffing issues in the NHS have become more publicly known. Now, on to reason why general practice specifically suffering a shortage of doctors. For young doctors who are just coming out of their foundation years of training, looking to choose the next stage of their career, general practice may seem to be a less lucrative choice compared to other specialties. With general practice, the working life seems much more sedate with less variation, though no less overload of work. Doctors may choose to specialise in a field that interests them most, and so there's a lack of doctors who feel passionate about all fields, or general practice. Creating more places for medical students is not going to provide an acceptable fix for the current shortage of physicians in the NHS. New medical students can take up to 10 years to become fully qualified consultants, and that's just one of the fastest possible career progressions, a path that many do not take. Instead, several other measures have been suggested to help spread the workload over the NHS more easily, to allow more efficient use of the current workforce. Firstly, providing more NHS workers with the ability to prescribe medication. If more healthcare professionals were able to prescribe medications, including physician associates, then this would reduce pressure on doctors, whose time would be better spent on other types of care that require their training more. In the case of general practice, this would mean that less qualified healthcare professionals, including the aforementioned physician associates, would be able to fulfill the task of prescribing simple medications for which the skill of an experienced doctor is not necessarily required. Secondly is a suggestion that the NHS should be open to graduates from similar non-medical fields, such as graduates from the biological sciences. In 2016, nearly 20% of these graduates were working in retail, catering and bar jobs 6 months after their graduation, all of which are jobs that do not make the most of their skill levels. Instead, these graduates could be allowed to enter fast-track extended nursing roles, which would enable them to use their education differently, while plugging gaps in the NHS. A study has found that people who have completed a medical degree are more likely to consider single specialty rather than general practice, while people who have not completed a medical degree but have studied in a field that is related are more likely to consider general practice if they are allowed. Finally, NHS trusts should be allowed to set their own wages. As I've mentioned before, the UK shortage of physicians is not evenly spread between the specialties. This inequality is further exaggerated by local discrepancies, with less desirable regions in England suffering from more shortages than others. The current centralised system of price setting and national pay structures make it incredibly difficult to address these discrepancies, with it being harder to attract junior doctors to areas where there's a deficit of workers. The pandemic has created a storm for the health service. Demand has skyrocketed, while the tax base has shriveled so much that funding is threatened even more than before. Efficiency savings such as those that I have just outlined are important in making the most of the healthcare workers we do have, and the pandemic has only exaggerated the need for these savings. And now I'll hand back over to Shrey.
I hope you've enjoyed our adventures into general practice. It's a wide and diverse role, which is very exciting, and I hope that you will consider becoming a GP. Remember to like, subscribe, and comment down below if you like this episode, and stay tuned for next week's episode.